Hey, good afternoon, everybody. Nice to meet you. My name is Dr. Jane Corrado. I am one of the developmental pediatric fellows here at Madigan Army Medical Center, and today we're really going to be focusing primarily on discussing quality of life measures. We have a whole host of topics to get through, so be patient. And if you need to kind of take a break in the middle of this lecture, kind of come back to it, no worries. But we're really going to hit on a number of big, meaty topics for sure. This is going to include things like autonomy, talking about consent and capacity, activities of daily living, and then even really hitting home on things like sexual reproductive care and health. Again, kind of covering a really big, vast array of topics, but ones that are going to be considerably important when working with your patient populations, especially those who have disabilities. So, back in 2009, actually, the U.S. signed something called the Convention on Rights of Persons with Disabilities. This is an international treaty that was actually inspired by U.S. leadership, and it recognizes individuals with disabilities and the rights that they have. And it really provided a vital framework for creating legislation and policies that embrace the rights and dignity of all individuals with disabilities. This is important because when you're practicing as a care provider, there's really this balance that you'll be playing with, making sure to meet and provide medical recommendations and provide quality care for your patients, and then also trying to maximize patient autonomy when you are giving those recommendations. And those things can sometimes feel like a balancing act. And you have to remember to really focus on the goals of the family and the patient when you're providing medical care and when you're providing some of those recommendations, and ensure that you allow families and patients to really have a voice and maximize autonomy. So, we're going to be discussing kind of underneath this umbrella of autonomy and kind of transitions for healthcare and how these all things kind of tie together, really under this umbrella of healthcare transitions, or kind of this planning, transferring, and then integration of adult centered healthcare, kind of that movement from pediatric care to adult care. And as that movement occurs, kind of incrementally increasing the amount of independence and autonomy these patients have, both to make decisions on their own and with the support of the medical community, as well as their families and other medical decision makers in their lives. And the goal of it is to improve the ability for youth and young adults to get access to specialized healthcare and meet their needs. And again, under that structure of autonomy and maximizing autonomy, and then also ensuring that there's an organized process for health transition. And so I think a lot of our other speakers have also kind of called to this, but trying to make sure there's this smooth kind of step moving forward from pediatric care to adult care. And once again, as that occurs, kind of maximizing autonomy along that way, along the way. So, the transition to adult healthcare cannot really take place, though, without systems and people providing services in order to maximize adult decisions, and meet kind of patients where they're at based off of their abilities and based off of what supports are already in place. So, when we talk about autonomy, I think everybody is fairly familiar with this, or at least they should be, from kind of going back to medical ethics when you were back in medical school, or kind of hitting a home on some of the principles that you learned maybe in undergrad. But autonomy, really, again, guys, is the rights of patients to make decisions about their medical care without experiencing undue influence for their health from their healthcare provider. So, our role is to provide information and then to maximize for patients to um, make educated decisions, and really all individuals with intellectual disabilities and developmental disabilities have the rights underneath the law to enjoy kind of and enjoy legal capacity to make decisions, and have an equal access to those rights as an individual without disabilities. And we have to remember, and we're kind of really going to hit home this throughout the presentation, that an individual adult or emancipated minor is always presumed to be competent to make their own decisions, and it should never, a medical provider should never go in and see a particular diagnosis in a patient's chart and automatically assume that they have a guardian or that someone else will be making decisions for them, but really targeting their discussions to the patient themselves, and no matter what supports they have within in place. Patient autonomy during transition from pediatric to adult care, I kind of hit home a little bit earlier, is it's very, very key and important. And once again, an individual must be presumed competent going into any medical decision. They also they must also be assisted to develop decisions, and through education, through supports, through life experiences, and we should really foster that education for our patients and really structure a good foundation for education within all of our different appointments. And then just because an individual struggles with communication, and this may be because of previous diagnosis, they may have an intellectual disability that inhibits effective communication. This does not mean that that individual should be um, viewed as not being able to make medical decisions or decisions with support. And so, once again, kind of making sure to keep a really open mind and approaching every single decision individually, and making sure to not kind of make presumptions is going to be really key and something to drive home for us today. And then a big component of this as well is ensuring that families have access to information about all of the options that are available for them to assist an individual throughout the course of that patient's life, especially if that patient needs more substantial supports. Sorry, guys, that was a tongue twister. Um, and then that is going to really be something we talk about a little bit later with regards to uh, making sure that you're educated on different state and federal programs that are in place that can aid an individual so they can maximize their own independence and have the most amount of autonomy in the least restrictive environment. And if you aren't aware of certain programs, say like SSI or DDA, or you're not aware of what type of insurance an individual needs to be applying for at particular ages, then you really do disadvantage these families, because then they aren't able to support their children who then become adults later on. So decisions that could be made, and things that we need to make sure we're maximizing autonomy for include things like making healthcare decisions, making financial decisions. All of these should be something that we bring up frequently and often. Reproductive care decisions, which we'll discuss later. And all of these decisions can be made kind of individually or with the support of other decision makers. And that includes healthcare proxies, advanced directives that are in place, powers of attorney, things like guardianship. But no matter what, as I made mention, all of these supports should be in place to offer the least restrictive supports possible so that an individual can effectively make decisions. And we should not immediately jump to guardianship, especially when we see a particular diagnosis in the chart, or only focus on obtaining guardianship. Really, we need to make sure that other more or less restrictive measures are in place or attempted prior to even discussing things like guardianship. Guardianship is a really, really big topic, and I think a lot of providers really want to understand the nitty-gritty details behind guardianship. And one of our other speakers has a full-on PowerPoint for you guys to refer and lecture on guardianship. So I don't want to drill too much into that, especially considering we had kind of some other big things going in today. But with regards to guardianship and autonomy, just making sure that regardless of an individual's guardianship status, all individuals should have opportunities to participate to the maximum extent in making decisions. And so they always should be consulted or always involved in some of those discussions as much as physically possible or able. And guardians should always engage individuals in decision making processes, ensuring that their desires or preferences are well known and are maximized. And then individuals with disabilities, once again, retain fundamental rights, both civil and human rights, unless they're limited by a court order, even if they do have a guardian in place. And those rights include the right to vote, make decisions about related to their sexual activity, and things like marriage and divorce, and also access to birth control. So just because an individual has a guardian in place does not mean that they've now lost any of those fundamental rights. And I think that's an important thing that patients and their families need to truly understand, especially given the discussion of guardianship kind of in pop culture recently. I really want to make sure that everyone is fully aware of what guardianship really entails. And so please reference that other lecture if you guys have any additional questions or anything like that. Next, we're going to kind of transition over to consent and capacity. So remember, guys, again, these are things that you learned about likely when you were in medical school or in undergrad, but informed consent requires that a patient is provided with information sufficient to understand and give approval for a proposed medical procedure or treatment. And so giving as much information as possible in a way that a patient can understand and at their education level is going to be key. I think a lot of medical providers, we do our very, very, very best in order to provide good quality education to our parents and to our patients themselves. But sometimes that results in overwhelming families or overwhelming patients with a lot of that medical jargon or over complicating things when really we can fully outline what is going on, what a procedure or treatment may entail or a diagnosis may entail in a more effective manner that is at the education level of that patient or of that patient's family. So I know it's really tempting to use all of our medical jargon, and I know it's something that we never want to oversimplify to the point that we're not conveying some things accurately or appropriately. But remember, guys, to kind of meet families and meet patients where they're at. Otherwise, you're actually not um, obtaining informed consent. You're leading to patients or families becoming overwhelmed and just approving things without kind of truly understanding what's going on, or rejecting things because they don't truly understand the details or the reasoning behind a particular medical recommendation. So, capacity, again, is the ability for patients to understand the significant benefits, risks, and alternatives proposed for a healthcare plan, and then to make and communicate a healthcare decision. So, again, there's a difference between capacity and consent. So, the ability of someone to kind of understand and give consent is going to be important. And remember, when we're assessing capacity of an individual, it's very question and decision specific. It is very time and place specific. So when we're going to be asking a patient, say, is it okay if we obtain your blood pressure right now or your vital signs? That is an individual has who may have intellectual disability has the ability to consent for that particular procedure. But if we have something that involves far more complexity, they may need to lean on their other medical decision makers or other supports in their life in order to adequately give consent for something, let's say, as more advanced of surgery or chemotherapy regimen, something that maybe they need more assistance in order to fully understand or to fully consent for. So again, an individual is always presumed to have capacity. It's not static, as I made mention. It changes time and place. It changes based off of what decision needs to occur. And then their example at the bottom is saying like, hey, if an individual say has something like epilepsy, that individual, when they are not postictal or did not just have a seizure, may be able to provide consent for a vast array of different medical procedures and actually may be able to understand very much everything that is going on and has a normal intellect, does not have an intellectual disability, doesn't have any other limitations outside of their disability, which is epilepsy. But following a seizure, that individual may be confused or somewhat altered. And so then they need to have a medical decision maker in place in order to say consent for something like surgery or other procedure that needs to occur after that seizure. So again, time and place, individual dependent, and decision making dependent. So that was kind of our discussion with regards to autonomy. That was our discussion with regards to what's important. We're transitioning from pediatric care to adult-based care, and our discussion with regards to consent and capacity. If anyone has any questions or thinks that was gone through too fast, please just refer back to the slides. They'll be available on the share drive. But a lot of those concepts, I do believe that have been covered kind of ad nauseum, probably during your medical education. But that doesn't mean that you should not refer back to them if you do have any additional questions. There's no shame of referring back to slides. I do it all the time. So when we're talking about transitions and the timeline for transition, I made it mentioned that we're going to kind of incrementally maximize the amount of autonomy that an individual has as they increase in age, and also ensure that individual has supports as they increase in age and we're not actually limiting their access to those supports because they've missed, say, a time window. And so know the timeline, know what is available and what isn't available for your patients based off of their age, and then also know the very complex kind of system that we live under in TRICARE or in the military medical system. Because you, again, do a disadvantage for your families if your response is, hey, I don't know. And when you go talk to only the case manager knows or only the local clinic social worker knows, because it may actually delay patients and their families from being able to access some of these resources. So when a child is about 12 to 14 years of age, and then the pediatric side, no matter the medical kind of history for a patient, we always really drill home the importance for parents and their children to really start talking about transition planning, ensuring that patients know what medical conditions they have, what medications they're on, why they're on particular medications, and then ensure that parents are making those discussions, having those discussions, I apologize, with their kids about what the transition to adulthood will likely look like. And then if an individual patient doesn't say have the ability to conceptualize that transition, then families really need to conceptualize it themselves too in order to prepare. So prepare early and often. Families really need to have discussions about what adulthood and that transition to adulthood is going to look like. Is a child going to go to college? Are they going to have any other continuing education? Are they going to go to vocational training, on the job site training? Will they need to stay in an adult day program? Will they need substantial supports? Move to a residential facility? Would they be able to live on their own? Will a child live with the family? All of these questions, when a kid is 12 or 14 years old, sometimes for families feel really overwhelming and big and even too early, but it's not too early because within 6 years or 4 years, that child is 18, and then soon that child is 21, and then soon that child may not have access to TRICARE based insurance. And so it's really very key for families to start having these discussions because paperwork takes a long time when you're thinking about applying for particular programs. And the last thing you want is paperwork to get in the way for families to be able to have the ability to kind of participate in things that may be beneficial for their child. When a kiddo moves on now to 15 or 16 years of age, that's typical when a lot of children will get a driver's license, which is used as a identification card. And I think a lot of providers and a lot of individuals in the world who have a driver's license don't really recognize how significant and important a driver's license or a state identification really, really is. It allows you to, it's asked for and it allows you to kind of have access to different parts of the world that can be limited if you don't have kind of proof of identification. This includes when you're attempting to, say, get a passport, when you're attempting to get a job, when you're attempting to apply for schools. You need a proof of identification, and this include you can use a birth certificate certainly, but the ease of having a state identification card and having a number affiliated with that state identification card is very, very important. We need to remember that it's not just individuals with intellectual disability or physical disabilities that may not have they may not be able to get a driver's license or kind of participate in a driver's test and obtain that license, but also individuals with epilepsy. So remember that in certain states there is legislation in place that limit when you can get a driver's license or have a driver's license, and when you can or cannot drive based off of your seizure frequency. So know those rules for your patients who have epilepsy and who have seizures. And have breakthrough seizures. So then that way you have those discussions early and often about access to a state identification card outside of a driver's license, because those patients may lose access to that driver's license when they get older, if their medical condition is not as well controlled as we would like or they would like. And then another thing to kind of talk about here is going to be having families work with schools in order to discuss things like the individual transition plans or extended education out after graduation or 18 years of age. And then also to discuss things like when the projected graduation date may be, are there any vocational courses that can be available within the high school or the school that this child is attending, and then what kind of the next steps are to kind of apply for those different programs. There's an awesome website on Got Transitions, which has a lot of timelines and ways to kind of assist with transitions in medical care, but also to assist with kind of uh, different programs to advocate for students, especially when kind of working with the school as well. When a kiddo is 16 to 17 years of age, we need to start discussing things like guardianship because it's going to be, again, around 18 when an individual is going to kind of there's a time frame where we need to obtain guardianship so that when an individual is 18, parents don't have the ability to say make those medical decisions. Again, a lot of things are state by state dependent, and if you refer back to the guardianship slides that the other provider is given, you may actually have to apply for guardianship again, depending on what state you're living in, if there's multiple different moves. And so at 16 to 17 years of age, we need to really discuss things like guardianship, um, especially before we even move to 17, maybe even more 15 or 16, because that paperwork and kind of getting those legal documents in place and talking with lawyers takes time. When an individual turns 18, remember that they still will fall under TRICARE until 21, but family within like different TRICARE based plans, but families should start exploring different insurance and federal and state benefits. And these include things like supplemental security income and then social security disability insurance. They also should consider applying for things like Medicaid, which gives access to different respite services or other state-based programs for individuals. SSI is Social Security program that provides monthly payments to adults with disabilities and children who meet Social Security disability and income criteria. Please have families go to the SSI website and review some of that information with them or have them talk to a lawyer because some of that criteria can be pretty strict, and families may be coming to you asking for different medical documentation that could be provided to the state so they could apply and then be accepted for SSI. And then the same thing kind of goes for SSDI, which is a monthly benefit for people who have worked in the past and paid Social Security taxes, but are now unable to work for a year or more. So there's different programs available state by state on what are offered. The number and then the different websites for enrollment are listed there for you guys to be able to provide to your patients and also review for yourself. When an individual is 18 to 19 years of age, if they say need to have that extended high school because they're unable, they need further education or vocational training or supports past 18 years of age, again, as we discussed when kids are 14 to 15, to make sure that we are talking with schools on when the projected graduation date is and what's available for extended high school or high school transition programs. But these are really post-secondary education programs, and they are something that the schools districts can offer and really allow students to still be actively involved in their high schools and get all of that vocational training that could be really helpful for them in the long term. During this age range, we also want to be considering things like applying for DDA, if an individual hasn't already applied for that through the Division of Developmental Disabilities. And this DDA and DDD they have different programs available for individuals with disabilities, and they have these programs. They're both in and outside of the home, both for vocational uh, abilities as well as therapy, day programs, different things like that. And so making sure families are aware of whether or not they qualify for things like DDA. For military families between the ages of 19 and 21, remember we need to make sure that we are looking up what other insurance a child could have because TRICARE will kind of fall off when they're 21 years of age if they're not actively enrolled in school. So for this is now our we've gone through that transition timeline. We've had a big discussion with regards to autonomy, consent, capacity. We've kind of talked about all of those different ages I think now we'll be making a transition to discussing how to effectively communicate with our patients when they're in your office, and in order to kind of effectively communicate with families and understanding what needs and what supports a patient may need to fully comprehend what medical recommendations you're giving, and also to ensure that they can give consent based off of their different, and for what procedure based off of their different abilities. So, adaptive functioning and communication, there are multiple different levels, including, and that really kind of goes into what a lot of us are familiar with, say, a mild intellectual disability, moderate, severe, profound. That's what we're kind of talking about here is uh, making sure to understand, say, what is someone's cognitive level, what are their adaptive skills or their skills in order to take care of themselves or activities of daily living, and then interact with the world and communicate with the world. And then how can we effectively communicate with that patient based off of those different levels. So uh, there are different adaptive functioning areas. Those include areas like self care, receptive and expressive language skills, social skills, learning skills, self direction skills or following directions, and then ability to have independent living as well as manage one's own finances. We're going to be discussing those, as I said, in the context of the various levels of intellectual functioning, and then also in the various levels of adaptive functioning. Just because someone's IQ is, say, a certain number, for example, 85, or say 145, does not mean that that individual has the same adaptive functioning skills as another individual with that number. When we're talking IQ as well, remember that our standard is for normal or kind of average range is between 85 and 115 for our IQ. Just because someone has a IQ that's above 115 or an IQ that's below 85 does not mean that that individual has the ability to care for themselves independently, or that individual has the ability to, yes or no, hold a job, um, or has the same ability to, you know, shower without supports or kind of participate in those activities of daily living. IQ is something separate from adaptive functioning skills, and I really want to drill that home. And that's because there are individuals, say, with things like autism spectrum disorder, who, in theory, could have a high IQ but lack those adaptive functioning skills, and that's part of their disability. So I really want to make sure everyone kind of separates out intellectual functioning from adaptive skills, and they do sometimes kind of go together, but they can also be very separate from each other. So, with intellectual functioning, when we're talking about an IQ of between 55 and 70, this is considered a mild intellectual disability. And typically, those individuals have kind of an age equivalent of understanding between a 9 and a 12-year-old. So, fourth grade to about sixth grade is what range we're really talking about there. If you think back to what a fourth grader to sixth grader can do, they can do quite a lot and have a lot of adaptive functioning ability and a lot of abilities for communication. That age range, when you're kind of thinking about someone's abilities, they have the ability to make medical decisions, especially those that are familiar to them. They have the ability to do a lot of independent self care. And then they also have the ability to have an unskilled job that involves like some, but not substantial supports in it. And they may also have the ability to, kind of have, live independently with like occasional check-ins, and really care for themselves more extensively than, say, some of the other more moderate, severe, or profound intellectual functioning categories that we'll discuss later. When it comes to communicating with patients with a mild intellectual disability, it's really important to use a variety of different sentence types, including simple and complex phrases. And that allows patients to, again, fully understand what you're saying, and you're meeting them where they're at and allowing them to then make an educated decision. Remember to use a vocabulary that uh, is targeted towards your audience, and individuals, again, between fourth grade and sixth grade have a pretty extensive vocabulary, but making sure to do check ins to ensure that you are adequately conveying the information appropriately. Making sure to write things down for patients and not rely solely on phone or phone or like in-person conversations, but really have clear instructions that you hand write and give to them or print out and give to them. And then ensuring that you're including their family if needed, but recognizing that again, these individuals have and should be presumed to be competent to make those decisions. Um, when we're talking about moderate intellectual functioning, our IQ range that we're discussing is going to be between 40 and 50. This is going to kind of cover an age range equivalent of between 6 and 9 years of age or up to around second grade. These individuals, for their adaptive functioning, typically need a lot more support when they're having employment, and they often do better if they're having some level or of supervision with where they're living, whether at home or in a residential area. They need help with managing finances. And then when it comes to things like having children, remembering that at the age range between like a 6 and 9 year old, it would not be necessarily appropriate for that individual to be able to care for a child independently. And so having those conversations, and we'll discuss that later with families on, hey, we need to really discuss things like consent with this individual, things like birth control need to be talked about, and then making sure that this individual kind of understands what is private and what is safe and is adequately supported in that kind of element of their care. When it comes to communicating with individuals with moderate intellectual disability, we need to ensure that we're using phrases and more simple sentences. Again, we're writing things down and in more simple ways, especially making sure to ensure that this individual has the ability to read and kind of checking in that they understand what you have written or told them, and then and trying to avoid things like more abstract language. And again, knowing that this individual has capacity to make those medical decisions that are more simple or routine, but also recognizing that that individual will likely need more support than an individual with more mild intellectual disability. For those with severe and profound intellectual disabilities, so for severe intellectual disability, our IQ range is between 25 and 35. Age range is between 3 and 6 years, so up to first grade. And these are really individuals that need far more substantial support, both in taking care of themselves and making medical decisions. The vocabulary can be limited. Again, it's important to kind of use more simple language when you're talking with them, though accurate language and not kind of in a tone talking down to them, and then ensuring that you're kind of including them into conversations, but making sure as well that you're involving family or their medical decision makers within their medical care. Profound intellectual disability are those with an IQ less than 20 or 25, and these individuals tend to be have few words that they speak or can even be nonverbal. At times, they can kind of seem like they're not interacting with you, but they do have, again, the ability to kind of understand, and they do have rights underneath the law and should be treated as a person and not as kind of an object or thing. And we want to make sure that they feel comfortable and are, there's a positive environment when we're making medical decisions with the family or with their caretakers for them, but making sure that we're maximizing their participation to whatever ability we can. Okay. They do need substantial supports again for caring for themselves and really will need kind of that 24-hour around the clock kind of monitoring, just like any child would. Um, just to kind of lean back, guys, they're not a child, they're an adult, but just like kind of any individual who kind of has their abilities. And I just want to make sure that we're not ever treating individuals who have intellectual disability just like children. They are adults, and that should be truly acknowledged. So that is kind of the different way of looking at IQ as well as adaptive functioning skills and communication skills for our patients who have intellectual disabilities. Again, every individual with a disability is not somebody who has ID. Those things are not mutually exclusive, but we really wanted to drill home kind of what different conversations may need to happen and how to kind of frame those conversations specifically with those who have intellectual disability. So, this is our last section today, and that's going to be discussing things like sexual reproductive health care. Sexual reproductive health care is very, very, very important and something that we should uh, not view as a taboo for our individuals who have disabilities. Individuals have the rights under Article 23 and Article 25 of CRPD, which is that Convention of Rights of Persons with Disabilities we talked about in the beginning of our discussion today. And these two articles discuss how individuals have the rights to have relationships and have a family, and to choose not to have a family and have rights to have sexual health care provided. And that falls underneath their right to have access to all forms of medical care. When we're talking about sexual reproductive health care, remember that though these topics are taboo, they shouldn't be. And it's really because of probably some fear and barriers and different cultural aspects within our society. And that taboo leads to us not providing for our families and for our patients and not giving them all of the resources they need. And it really does a disservice. Often, individuals with disabilities are overlooked both by the community as well as the medical community. And this leads to individuals being marginalized, and it leads to a greater gap in education. And then this gap leads to an increase in possible and vulnerability and possible abuse. And so, if an individual with disabilities are not provided with proper education and medical care, they remain ignorant and to basic facts about their bodies, about their rights, and about relationships. And once again, that kind of results in this space or void, which can lead to possible manipulation, exploitation, and then abuse. And those with disabilities are at 3 times more likely than individuals without disabilities to be victims of sexual abuse or physical abuse. And so, by you not being scared to have these conversations and you not being awkward or you not shying away from them, this allows families to not shy away from those conversations and really kind of refrain our focus and our discussions so that they're positive ones, especially about things like sexual health. So the common misconceptions, so individuals with disabilities are not sexually active and therefore do not need sexual reproductive health care services. I think hopefully all of us should know that that is a lie and totally incorrect. Those with disabilities have the same kind of hormonal urges, have the same can have the same desires to have a relationship, to have a family, have their own abilities to and rights to have explore their gender identity, and their like interests in sexual partners. And so again, by having this like misconception floating around in our heads through whatever means, really results in us just limiting them from getting the care they need, and also just increases their risk and your risk as a provider to not give them what they need. So, how do we have these conversations? So, with families, really again, that open environment. If any of you guys remember going through a medical school or whatever medical training that you did receive, I'm sure we all talked about like the heads exam. We all talked about interacting with teenagers. We all kind of talked about kind of having open discussions about sexual health care. And this really goes back to those same foundations. So we need to clearly make sure that families are discussing things about privacy and intimacy. We need to make sure that families are discussing things about what is needed for appropriate supervision, especially for those with intellectual disabilities. We need to make sure that families and patients are defining things like consent. We are also kind of opening the floor to not just conversations about sexual relationships, but friendships and what friendship means and how that's different from a sexual relationship. And then we need to clearly define things like dating. So, just like having conversations with teenagers or any of your adult patients, the same rules really apply, and we need to hit home on the same kind of meaty conversation topics. A lot of families, for individual who with individuals with disabilities will have a lot of questions, and you just need to be ready for these questions and kind of, really dive right in and make sure that families feel comfortable asking these questions. Common ones that we see in our practice are things like, how do I help my child learn about dating? How do I keep my child safe? Should I talk to my child about birth control? Should we be talking at all about birth control? And then how do I explain things like self touch? And how do I explain that those things should be kept private? And so making sure that if your families aren't asking these questions, you start asking these questions and kind of plant them in the back of their minds. And don't allow families necessarily to deny that kind of these are questions that we should be talking about, because things like things like this definitely do come up. So, other kind of conversation starters that we can have kind of fall under different categories, including discussions on gender, appearance, relationship, family, sexual communication, and life choices. When we get started with talking to patients themselves, we can use kind of really standard lines like, hey, sometimes patients feel uncomfortable talking about private things. I want to ask if it's okay to ask you questions about your body and some private issues so they can help take care of your health. So, kind of that standard, like, hey, I want to take care of you. Some people find this awkward, but I want you to know that this is a safe place for you. Just kind of, again, that similar lingo that you had when you guys were going through kind of just making discussions with your teenagers is similar lingo that I want us to use here, especially when we're working with those who have intellectual disability, both mild and moderate intellectual disability. Um, the kind of important questions that we highlighted again in the different categories. So, we need to make sure that individuals understand consent. We need to make sure that they know what is private and what is allowed to be viewed in public. We need to make sure families are having conversations about kind of sexual identity, about gender identity, about different sexual activities, including things like just blatantly what is sex, what do you understand sex results in? What are the goals of sex? Things like condom use, birth control use, things like sexually transmitted infections, especially for individuals who are kind of coming in who are sexually active, making sure not to shy away or from these questions and not to shy away from asking, hey, are you sexually active for our patients, no matter what kind of diagnoses are written on the sheet. And then making sure you're having conversations about things like abuse and coercion. So then that way there's a safe and open conversation between your families, your patients, and with you. We do need to start to talk about things like fertility and reproductive care. And kind of falling underneath of that, we need to make sure, and we'll get to this, having conversations about things like contraception. When we are having discussions on reproductive health care in the clinic, we make sure kind of when we're talking about all these different question categories that we are repeating ourselves over and over and over again. So then that way we're truly getting the information that we need. And so that way we can care for our patients effectively. We're using simple, concrete examples and questions. We're not kind of going into the abstract. We are practicing real world social situations. For example, what would happen if someone came up and kissed you on the lips? What would happen if somebody touched you here? Kind of those sort of conversation examples need to happen. We need to try not to overwhelm our patients and their families, and so kind of having these conversations incrementally over multiple different appointments may be helpful. And then we need to start with the basics and work up from there. And we need to go past just the birds and the bees because we need to remember that individuals with disabilities do have sex, do have relationships, and you're doing a disservice by not kind of going into the nitty gritty details with them. So on the now moving on to our conversation about contraception. So remember, women with disabilities have a right to decide whether or not they want to be pregnant or not pregnant, and they have a right to access to information and counseling regarding contraception. There are a multitude of different ways of offering contraception to this community and to have those discussions. And the options for contraception are just as broad and available as if you were talking to anyone else. We need to make sure that the contraception we are offering and educating our families on and recommending are matching with their goals. So, an individual may be interested in contraception because they're interested in, say, preventing pregnancy, but a family and an individual may be interested in contraception because it may offer them, say, to have less of a long period or to have a shorter period or less heavy period, so then they have improvement in their ability to do self hygiene. It may also be that we need to kind of talk to families who are on different medications about the interaction between birth control options and those medications. And we need to have those conversations in an open and honest way as well. So then that way, expectation and goals are matching up with what we prescribe. Uh, I don't need to go into the details of all the different methods for hormonal contraception. I think a lot of us are very, very aware of what those options are. We'll be posting a whole slide deck on contraception that was given to us by one of our adolescent medicine providers on the share drive. And so if you want to kind of go into the details about estrogen and progesterone only OCPs versus IUDs versus Depo-Provera versus kind of patch options, please refer back to that. There's not a recording affiliated with it, but it is very, very helpful. There are non-hormone options, including things like the barrier method, and then there are behavioral methods like the withdrawal or natural family planning method. And the last thing I want anyone to ever think of when they're thinking of contraception for this community is to think of sterilization or endometrial ablation. Those are two kind of categories of contraception that are very, very controversial, have horrific historical backgrounds to them, and really should be offered or even discussed as a last resort with families. And kind of making sure that if a family is coming looking for those things, to kind of discuss why is that their goal, and then to be able to provide them alternative methods of birth control, or like hormone suppression or X, Y, and Z or hormonal options that could actually also meet those goals as well. And so, again, when we're talking about sexual reproductive health, we need to make sure that we are kind of meeting families where they're at, meeting patients where they're at, offering them adequate education, allowing women to make educated decisions, and then making sure that we're maximizing their autonomy and then their rights underneath the law. We really went through today like a vast array of information. We talked about things like autonomy, we talked about support and independence, we talked about the transition from pediatric care to adult care, and we talked about sexual reproductive health. And we really talked about advocating for our families and our patients so that they can have access to care. Um, there was so much information there, but I want you guys to always feel free to look back at all of those different slides. And then if anyone has any questions, they can always look back at the references that we offered. And please, please, please email one of us within the developmental pediatric community. And I'm here at Madigan Army Medical Center, and any of the attendings or fellows would love to answer those questions for you. I hope this was helpful. I hope everyone has a great day, and thank you for your time. And it was good working with you.